Welcome to Hedgehog Radiology, our very first video. What a treat! We will do the very classic thing, which is to learn how to read a chest x-ray. The chest x-ray is one of the most common imaging studies in medicine. We will go through a pretty simple system you can use every time, so you never miss a finding. Are you ready? Let's get started. Here is a chest x-ray from the back, aka a PA view. It looks simple, but it is not. What you are looking at is a two-dimensional image of a three-dimensional space. The heart, the lungs, the ribs, the spine, the blood vessels, everything is here, but it is all layered on top of each other in one flat picture. Look at the difference between the front view and this lateral view. You can see how much depth there is in the chest. On the front view, all of that depth is compressed into one single layer. This is what makes the chest x-ray difficult to read, and this is why we need a system. But first, let us learn the normal anatomy. Before we look for problems, we need to know what normal looks like. Here is the big picture. This area is the thorax, the chest. Above it is the neck. Below it is the abdomen. Everything inside the rib cage is the thoracic cavity. The chest x-ray shows all of this in one image. Our job is to look at every part, step by step. Let us start with the bones and soft tissue, out skin and fat and stuff. In our system, these are the outermost structures. The first thing we check. Here are the ribs. There are 12 on each side. 7 connect all the way around. True ribs and 5 do not false ribs. In the front, they connect to the sternum, the breastbone. In the back, they connect to the spine. At the top, you have the clavicles, the collarbones, and behind the lungs, you can see the scapulae, the shoulder blades. Sometimes the scapulae overlap the lungs on the image. This is normal. Our job as radiologists is to not confuse normal things with something abnormal. Now let us move inward to the lungs and the airways. Air enters through the trachea, this tube in the middle. The trachea divides at a point called the carina. It splits into the left and right main bronchi, one for each lung. The right lung has 3 lobes, upper, middle, and lower. The left lung has only 2 lobes, upper and lower. Why? Because the heart sits on the left side and takes up space. So the left lung is a little smaller. This is normal. So instead, the left lung gets a lingula, not a full lobe. Around each lung, there is a thin lining called the pleura. On a normal chest x-ray, you cannot see it. This is important to remember. If you can see the pleural line, something is wrong. What you can see are the angles. Down here, where the lung meets the diaphragm, these are the costophrenic angles. They should be sharp and clear. If they look blunted or filled in, that usually means there is fluid. And here, where the lung meets the heart, these are the cardiophrenic angles. Always check these. Now we are at the center, the mediastinum. This is the space between the 2 lungs. The upper part is the superior mediastinum. The great vessels and the trachea are here. The lower part is the inferior mediastinum. The heart sits here. The heart has 4 chambers, the right atrium and right ventricle on this side, and the left atrium and left ventricle on this side. The left ventricle forms most of the left heart border. This is the border we look at when we check the heart size. Here is a useful rule. On a PA chest x-ray, the heart should be less than half the width of the chest. If it is bigger than that, the heart may be enlarged. This is called cardiomegaly. Here is the lateral view. This gives us the depth we cannot see on the front view. Here is the aortic arch curving over the top. Follow it down. That is the descending aorta running along the spine. In front, the ascending aorta comes up from the heart. You can also see the SVC, the superior vena cava, which brings blood back to the heart from above, and the IVC, the inferior vena cava, which brings blood back from below. The pulmonary veins carry blood from the lungs back to the heart. You will not always get a lateral view, but when you do, it gives you very useful information. Now, let us put all of this together into a system. Here is the system. It is called the outside-in approach. You start at the edges of the image and work your way to the center. Having a system makes sure you look at everything. Here is the order. Step 1, bones and soft tissues. Trace each rib, check the clavicles. Look at the soft tissues of the neck and chest wall. Look for fractures. Step 2, the pleura. Follow the edges of the lungs. Are the costophrenic angles sharp? Do you see a pleural line that should not be there? Step 3, the lungs. Compare left and right. Are they the same darkness? Is there a mass, a cavity, an area that is too white? When an area is too white, it means increased density. We call this consolidation. Consolidation is often a sign of pneumonia, and pneumonia is one of the most common reasons a chest X-ray is ordered. Step 4. The mediastinum. Is it a normal width? Is the trachea in the midline? Are the hela, the areas where vessels and airways enter each lung, are they symmetric? Step 5. The heart. Is it enlarged? Are the borders clear? Now let us see real cases. Look at this chest X-ray. If you look only at the lungs, they appear normal. But we do not start with the lungs, we start with the bones. Look at the ribs on the left side. Do you see the breaks? The white line of the rib is interrupted. We call this a cortical break. These are rib fractures. They are easy to miss if you are not looking for them. Rib fractures are not just about the ribs. Multiple fractures next to each other can create a flail segment. This affects breathing, and if the lower ribs are broken, you must think about injury to the liver or spleen, which sit just below. One finding leads to more questions. That is how radiology works. Look at this chest X-ray. The right upper area looks different. There is extra whiteness. The right upper lobe is more dense than normal, and it looks smaller. This lobe has collapsed. Look at the border between the collapsed lobe and the rest of the lung. Look at the shape. Near the center of the chest, it curves outward, convex. Then as it goes toward the side, it curves inward, concave. This makes an S shape. This is called the golden S sign. Why does this happen? Normally, when a lobe collapses, it folds inward in a straight line. But here, there is a mass at the hilum, where the airway enters the lung. The mass is blocking the lobe from collapsing evenly. It is pushing the fissure outward and creating that bulge. The lung is collapsing around a tumor. So the golden S sign tells you two things. The lobe is collapsed, and the cause may be lung cancer. Now we check the pleura. Look at the right side of this chest X-ray. Do you see a thin white line running along the chest wall? And beyond that line, there are no lung markings. It is just black. This is a pneumothorax. Air has entered the space between the lung and the chest wall. The lung is being pushed inward. It has partially collapsed. Remember, on a normal X-ray, you should not see the pleural line. If you can see it, air is in a place where it should not be. A pneumothorax can be small or it can be very dangerous. Let me show you the dangerous version. This is a tension pneumothorax of the left lung. Look at the difference. The entire lung on this side has collapsed. And look at the trachea and the mediastinum. They are pushing to the opposite side. Can you imagine that? The air pressure is so high that it is shifting all the structures in the chest. This is an emergency. The pressure is compressing the heart and the other lung. Blood cannot return to the heart normally. If this is not treated immediately, with a needle or a chest tube to release the air, the patient can die. Finally, we reach the center, the mediastinum. This chest X-ray is from a trauma patient. Many people would look at the lungs first, but look at the mediastinum, the central shadow between the lungs. It is wide. It is wider than normal. The mediastinum should be less than 8 centimeters at the level of the aortic knob. Here, it is clearly more than that. In a trauma patient, a wide mediastinum is a very serious sign. It can mean the aorta has been torn. We call this an aortic transection. The aorta is the largest blood vessel in the body. A tear in the aorta is one of the most urgent findings in all of radiology. This patient needs a CT angiogram immediately and probably emergency surgery. Thank you for watching. I wanted to get this first video done and it had to be about chest X-rays. No other way around it. I hope you found it helpful. Next video, I will talk a little bit about radiology as a career and other radiology adjacent jobs. And I will also talk about what kind of videos I want to make on this channel, my motivation for it. So I hope you will find that interesting and helpful. Have a blessed day, my friends, and see you very soon.